is here along with Dr. Gulati, Kesarwani, Marmagkiolis being replaced by his colleague, Dr. Palma, Dallan, and Dr. Davies, and Dr. Al-Ogaili. And with that, we're happy to get started with our very first visionary talk about the future of intravascular imaging. Dr. Palma, Dallan.
Good morning, everyone. So thank you so much for being here. Thank you, Manoj, for the invitation. Always a great pleasure to be here with friends, with colleagues, and this great city of Austin. So the theme today is the future of intravascular imaging. Actually, we're going to start talking about the present of intravascular imaging for two main reasons. The first one, it's not widespreadly used. I wouldn't say most, I would say many of the operators are not using that routinely. And as Dr. Jaffer said, it's a class 1, so we should use for most of our procedures, right? So that's the first thing. The second thing is that most of the things that I'm going to show here, they are already available. They are commercially available. So we should use those tools before thinking of going forward with the new technology. So the main modalities, as we all know, it started with fluoro many decades ago, and then we evolved to IVUS and then OCT. And I think the tendency now is to have an association between anatomical and physiological strategies in the future, right? So we have IVUS, we have OCT, we have NIR, for example, that we don't use that much, but it's a great tool for us to detect vulnerable plaques. So if you have that 40–50% lesion that you don't know if you should stent it or not, if you knew that you could predict that that could end up with a STEMI a few months later, I think that we all would be able to stent it and prevent ACS event for our patients, right? For example, OCT has a better resolution, IVUS has a better penetration, and if we can have both of those growths in one catheter, that will be amazing, and especially without use of contrast as we have to do in OCT. So when should we perform IVUS or OCT or any kind of imaging? The answer is always. We always have to use some kind of imaging for our procedures so that we can have better outcomes. Pre or post PCI, we have to use both pre and post PCI. We have this paper that we participate with the fellows from Harvard, Kevin Cross, and Rhian Davies, where we show that 8 out of 10 times we change our strategy if we use intravascular imaging, especially OCT. Okay, so I think that this is a great number, and because of that, I think we should use intravascular imaging for most of our patients. With that, we came up with this mnemonic MLD Max, where you can have access before the procedure, pre-procedural imaging with morphology, length, and diameter, and post-procedural post-stent, we can assess the dissection, we can assess the position, and stent expansion. What are the main evidence for superiority of intravascular imaging? So we have studies of OCT versus angiogram, IVUS versus angiogram, IVUS versus OCT, and we have the integration between intravascular imaging versus angiogram. And if you put all together, especially with meta-analysis, we can see that we have better outcomes when we put together any type of intravascular imaging compared to angio. So that's why we have to integrate these strategies in our everyday practice. So here are the guidelines from the European showing that it's a class 1A, as Dr. Jaffer said, to use intravascular imaging, especially for complex lesions, bifurcations, calcified lesions, left main. And in February, the American guidelines, they shift, and they are now a class 1 recommendation in America as well. Now talking about the future, actually the commercially available new advances in intravascular imaging. So we have like real-time, less invasive modalities such as QFR, FFR, where we can have immediately physiology when you do angiogram. We already have the integrated modalities such as OCT plus IVUS to analyze the images. We have the artificial intelligence guiding us how to place the stent, how to post-deal the stent. We have fusion between the fluoro and the CT to help us to guide the procedures, and we have integrated anatomical and physiological features with OCT and FFR. So we know that when we do, for example, an IVUS, we can defer the treatment of the lesion if we have like a large minimal lumen area, but we cannot indicate to treat the lesion without physiology. So if we can have that at the same time, that will be amazing. We have a lot of angio-derived FFRs software such as QFR, VFFR, and with that we can have at the same time that we do the angiogram, we can have the FFR. I think in the future we don't have to wait for the image to be processed to get the final result. I think that we'll have a real lifetime injection with the showing immediately where's the FFR, if we have a focal lesion, if we have a diffuse lesion, and where to place the stent. I think that's the future of the FFR. Derived from the angio. So we already have some catheters that they do both IVUS and OCT. So you can have both, best of both worlds with one catheter, with better images from OCT, better resolution, and a more deep imaging inside the vessel. And some papers such as this one from 2021 showing that it's safe and not associated with any complications, and you have an improved plaque characterization by using both IVUS and OCT at the same time. We have an association between OCT and ears, so we have these tools, these catheters that you can do OCT and ears at the same time. So not only you have the plaque characterization, but you can detect the vulnerable plaques and treat it accordingly. Of course, yesterday we had this great panel with Dr. Sandoval discussing the CT pre-planning for the coronaries. So we have so not only you can select the guide, you can see a plaque characterization before going to bring the patient to the cath lab, but you also can have a virtual FFR to know exactly where to place the stent and what is going to be the expectation after you place the stent, right? We have this great, yesterday night, we had this great innovation presentation where they discussed the future of heart flow and other features. So I think there's a lot coming and a lot new technology coming to help us. Yesterday, Dr. Shah, in the same presentation, and the CTA panel, showed a great case where he got a CTO of the RCA, and he put together fluoro and CT roadmap. So he was able to see at the same time the fluoro and the roadmap where was the CTO of the RCA. And so such a complex procedure became a very easy procedure. He was able to wire the vessel exactly where it was and to turn a complex into a simple procedure. So this is not the future. This is the present, and all these technologies are up and running. We just have to start using that in our practice, right? So sometimes you need a better structure. So this is our hybrid cath lab, where Dr. Philby is the director at UH CMC, where we have in the same physical space. We have cath lab, we have CT and MRI in the same physical space. So sometimes you need more structure to do some of those procedures. And finally, I think the new generation of the Ultron, the new generation of artificial intelligence associated with OCT will give us a better sense of where to place the stent, how to measure, how to pose DIL, and not only that, but also to integrate FFR to the OCT. So I think the Ultron 3.0 not only will have the features of the stent, but also will have the features to predict the FFR after the stent. Almost done here. We need to widespread the education of that. Not only we have the technology, but have to have some training for that, so that everybody is able to know how to use, how to see the image, how to interpret the image, and how to react properly of what you're seeing. So the final learning points. The future of intravascular imaging will have integrated anatomical and physiological features. We have a combination of IVUS, OCT, NIRS, everything, and FFR together. We'll have a bigger role of artificial intelligence in predicting the pre and post procedure features, and we'll be able to have better outcomes for our patients with that. Thank you so much.
Great presentation. I want to start you with a question that I think a lot of us that do image frequently wonder, and that is, if less than 20% of operators in the US use intracoronary imaging, what can we do if we know that the evidence base is so good and that outcomes are so much better to help bring our partners around the country to the conclusion that we need to use more imaging? What do you think? And I'll throw that out to the whole panel as well, because I think that's a big question that sits in the back of all of our minds in this session.
That's a great question. I think that most of those operators don't use because they don't know how to interpret and how to react to it. They are afraid to use that. That's the biggest point. So to answer your question, we need education. We need education so that everybody is very familiar with the imaging. We can see the image there, we can interpret and know how to react, right? So we have those apps that I showed that they have a self-learning. You can just open the app, you can go over images, and it gives you immediately the answer of what you are seeing and how to react to that. So I think that's a great opportunity. It's for free, and you can do a self-learning based on that. So I think we have to capitalize on education.
I agree that, industry has done a lot to try to motivate folks to learn and interpret their own imaging, and you can do it from the privacy of your own home with a lot of the tools that are out there. I know with the Boston HDIVIS, with Abbott and OCT, there's online modules, just click through, learn it, figure it out. It has the time to know what you're looking at is when the patient's not on the table. So working through and asking support from them is a really easy resource.
Not much to add, but I think you nailed it. The future of intravascular imaging is getting the current imaging generalized to the broader interventional community. I think these apps are good, but I don't think they're the solution. I know industry is trying with AI to de-educationalize us and make it not necessary, but I think that's the wrong thing to do to rely on. So all of what you said, I completely agree with.
Yeah, regarding the barriers of why people don't do intravascular ultrasound, people have looked into this, and number one is the economics. The people are worried that they're not going to reimburse for it. Number two, the time, extra time that adds to the procedure. And then number three, as you mentioned, was the fact that they're not sure exactly how to interpret. So I think that once reimbursement gets better, once people understand and have awareness of this data, that will be the things that will help with us move forward.
There are great points. The first one, the reimbursement. Most of these are reimbursed at this point, the basic ones, IVUS and OCT. So there's not an excuse of reimbursement. So not only that, you get more RVUs if you use those images, right? The second one is the availability. I think that we have widespread availability of those tools in our CAD labs. And so I think the bottom line, once again, is the education. I think that they are afraid to use it. We have evidence, we have great outcomes, safer, more efficient, so we should be using in most of our cases.
Two things that'll further drive increases. Number one is that these are now Class 1 guidelines, so there really is going to be that impetus to do the right thing for at least the more complex lesions there right now, but we expect that to probably generalize. Second thing is people may be aware that in Michigan, Blue Cross Blue Shield has initiated a quality program for payment to be at the highest tier for hospitals. There has to be a certain amount of intravascular imaging used, and it's gone from 40% to now 60%. So it is a mandate that at least the healthcare payers are realizing that this is going to reduce restenosis for their system and reduce stent complications. It's hard for an individual operator if there's a 4% restenosis rate and someone's doing an average of 100 cases a year. It's hard for them to realize that a 4% rate may drop to a 2% rate. People just don't think they actually have restenosis. But from a system level, when you multiply that by thousands, you can realize the incredible impact that this is going to have across systems. So I think some of these will pay out in the payer environment as well.
Definitely. If you have a technology where you change 8 out of 10 times where you use imaging, you change your mind, you change your strategy, I think that's relevant. So we have to put this into account and start using more intravascular imaging in our procedures.
With that, why don't we go on to our next talk? Thank you. So Dr. Kesarwani from Davis is going to help us find the culprit.
Great, thank you. So on the coattails of that question, I think conferences like this are just wonderful opportunities to really spread the mantra of the importance of intracoronary imaging as well as coronary physiology, as we discussed in the last session. I have no disclosures relevant to this presentation. So I like to address this topic by a case presentation, and I like to run through kind of how we approach a STEMI or acute coronary syndrome presentation at UC Davis. So in our area, Sacramento, we have a very large Hmong population, and so it's no surprise we had a 46-year-old gentleman present with no past medical history with a pre-hospital activation STEMI due to chest pain while playing basketball. After obtaining a 12-lead ECG, he underwent a left heart catheterization with course with the possibility of PCI, and this is his out-of-hospital ECG where there was concern for anterior ST segment elevation. You'll see in the inferior leads concern for reciprocal depressions. And so on the coronary angiogram, what we see here in the bottom left corner is a right coronary artery with no severe disease. Non-obstructive coronary disease is the way I would describe it. And then we move on to the middle image here. We start to notice that there is plaque disruption in the proximal LAD. There's intermediate disease, at least in the left circumflex system. And we also notice this as well in other views, in the iliocranial view as well as the areocranial view. So the way we approach this patient is that we did decide to pre-dilate before performing intracoronary imaging, but we decided to tackle it using OCT. And so this is an OCT run showing quite a bit of fibrous plaque and then disruption of the fibrous cap here, consistent probably with plaque rupture. And so I'll let this run for you to review. And so moving on then, with the algorithm, we did our pre-PCI OCT run thinking about the morphology, lesion length, and diameter. We go on to perform our PCI here where we did further predilation and only placed a stent here. And so we're looking to see if there's any evidence of distal edge dissection, a proximal edge dissection. We know from the Limian 4 trial that proximal edge dissection and minimal stent area are really key features to optimizing our outcomes after PCI. And so you see a reasonable result here where we have very minimal malapposition, less than 200 microns. And then you see the angiogram post-PCI images showing no severe residual disease. And then we follow this up with coronary physiology, doing a QFR assessment, seeing here that the QFR value is 0.94. Our target here is 0.89 or greater. And so this is a good result, I would say, based on OCT imaging. But the way that we interpret OCT, the way that I tackle it, is I really think about, can I see the intima, the media, and adventitia? Can I see all three through the entire circumference of the vessel? And if I can, and there's minimal thickness of the intima, that'd be a normal vessel. If we do see some thickening of the intima, oftentimes that's fibrous plaque. And then if we get in a situation where we're not able to see the intima, media, or adventitia, we're asking ourselves, where is the source of signal change? So if the signal change is at the level of the lumen, I'm thinking about plaque disruption. And so we'll think about more red thrombus when there's high attenuation. We'll think about more about white thrombus when there's low attenuation. In fact, in the pre-PCI images, we did see some evidence of white thrombus. In fact, after we did PCI, we saw some plaque protrusion as well, with a little bit of white thrombus. In that case, we decided not to post-dilate aggressively and to use cangrelor to help dissolve some of that thrombus. And then if we see that there is source of signal change at the level of the vessel wall, then we're wondering whether the patient could have lipid plaque. We talk about a muddy appearance to the image. And then we're thinking more about calcific plaque when we see islands where we can kind of draw out the borders, as we see in this example here, where we're seeing more low attenuation as compared to high attenuation in lipid-rich plaque. And this is just a correlation, just emphasizing the idea here that we see a disrupted fibrous plaque. So this is plaque rupture. And then throughout the OCT run, we also see evidence of thrombus. So we have to know what we're looking for, though, when we're thinking about a culprit lesion. We need to think about plaque morphology and culprit lesions in ACS. And so when we have definite plaque erosion, what we're seeing here is we're seeing endoluminal thrombus, and we're also seeing actually a little bit of plaque throughout the whole circumference of the vessel. We often say there's denudation of the endothelium. And then we have situations where we have probable plaque erosion, where you do again see interluminal thrombus, but here you're not seeing behind that thrombus, and so you're not able to truly say that this is plaque erosion, so we call this probable plaque erosion. And then with plaque rupture, we clearly see disruption of the fibrous cap as shown in this example. And so it's important to remember with plaque erosion, that represents about 30% of ACS presentations. Plaque rupture is by large the majority, but then in about 9 to 10% of patients, we'll see that they'll have an eruptive calcific nodule. And so with that calcific nodule, what we notice is there's calcium throughout the circumference of this vessel, but as shown by the arrowhead, there is an eruptive calcific nodule shown there. And again, representing about 10% of the cases where perhaps using rotational atherectomy, if there's no associated thrombus, could be an option, or using intravascular lithotripsy. So here's a more complex case presentation where I think intracoronary imaging, particularly OCT, was very helpful, but we're using all of our tools available. So this is a 61-year-old woman that was transferred from a skilled nursing facility to the ED with dizziness, mild confusion, and fatigue for 3 days, but no obvious chest pain. So even the presentation is not clear-cut for an acute coronary syndrome. Her past medical history is only significant for chronic adrenal insufficiency, and her 12-lead ECG is shown where there's Q waves in the inferior leads as well as SC segment elevation. So the patient is referred to the cardiac catheterization laboratory, and what we find here is particularly in the prox to mid circumflex, there is probably some plaque disruption, but it's not clear cut, and we see TIMI3 flow. So it's not consistent with a STEMI. And so we have other views, including the LAO caudal view, as well as the LAO cranial view, also displaying that plaque disruption. So given there's no angiographically obvious culprit lesion for this inferior lateral STEMI, we anticipated that we would need to fix the right coronary artery, so we went up with a guide catheter, and lo and behold, we see that actually there's TIMI3 flow throughout the right coronary artery with very minimal disease. So in this situation, we're going to utilize the left ventriculogram, and the left ventriculogram really points out that there is injury to the diaphragmatic wall, inferior wall of the left ventricle, so we have to be on heightened alert for the perhaps that we missed a flush occlusion, for example, or perhaps that lesion that we noted in the proximal circ could be the culprit. And so what we did here is we performed OCT, and what we noticed with the OCT are we see microchannels and disruption of the fibrous cap here. So this might suggest plaque destabilization that happened in the past, but not active. I will point out, though, that there is some white platelets, or white thrombus, I should say, filled with platelets noted as well. And then the laboratory data is not even that helpful because a patient is presenting initially with a troponin of 15 that only rises to as high as 102. That's evident during the case here. And so when we correlate the coronary angiogram to the OCT images, again, what we're seeing are microchannels in the mid-circumflex with a minimal lumen area of 1.8 millimeters squared with platelet-rich thrombus. And then we also see interruptions in the fibrous cap with minimal presence of thrombus suggestive of plaque rupture with ongoing healing as mentioned previously. So we know in this situation that it's probably best to go ahead and proceed with PCI with the idea that with this patient already having plaque destabilization perhaps in the last couple of weeks, that the patient's at very high risk for this to recur. So we go ahead and scaffold, and I'd say to you that this seems like a reasonable result by OCT. I'll admit the run's not that great with the proximal portion, but we're seeing, with a lot of sural artifact, but we're seeing a good stent opposition. We're not seeing any proximal edge dissection. We're not seeing any distal edge dissection. We're not seeing any protrusion of plaque. So when I encounter this type of situation where I'm identifying the culprit lesion, I always like to take a pause and think about the clinical data that I have available. You want to look at the ECG, you want to consider cardiac biomarkers, and you want to develop the working diagnosis of an acute STEMI or a non-ST elevation ACS. And then in terms of the coronary angiogram, we want to really pay attention to where the ECG or the point-of-care ultrasound is localizing to in terms of the culprit vessel. And the diagnostic coronary angiogram, we want to look for a vessel cutoff or residual contrast or dye or hang up to suggest a culprit lesion. And then we want to make sure that all walls of the left ventricle are accounted for with our coronary angiogram to make sure we're not missing a flush occlusion, for example. Then we're going to consider intracoronary imaging. It certainly doesn't have to be OCT, but OCT is going to be the best modality to really see plaque erosion, again, representing about 30% of ACS presentations, which is very difficult to pick up by IVUS. We also have the options of near IVUS as well as OCT IVUS. And then obviously you want to treat the culprit lesion. That's the goal in this type of situation. And so the key learning points here is when clinical data suggestive of ACS in the coronary angiogram, but it's ambiguous, we really do need to think about intracoronary imaging to help cinch that diagnosis to identify the culprit lesion. You also want to remember that plaque erosion is a distinct histopathological and clinical entity that also counts for ACS. There's been some argument that when we have plaque erosion that perhaps we don't need a scaffold, but the data is not yet clear-cut there. And then remember that we also have healed plaque ruptures that frequently present at the culprit site in ACS and are a risk factor for rapid progression of atherosclerosis. Thank you.
Thank you. Great presentation. I had a question for the panel and for you, and that is, how many of you all use both IVUS and OCT? And besides, you mentioned at the very end that you tend to use OCT for your infarcts because it's easier to see the culprit lesion. But when do you, or if you do, prefer OCT versus IVUS/HD IVUS in your practice for the panel?
Yeah, I mean, I personally have both in my lab. I'm a lot more comfortable with IVUS in general, but I think this is one area where OCT definitely trumps IVUS because of higher resolution. These like Minoka cases for sure. But in general, I would say 90 to 10% IVUS OCT.
I use most of the time OCT when it's available. One of my labs just have IVUS, so I use IVUS. But when I have both, I use mostly OCT. Unless it's a CTO, where you cannot use it, or if you have a very large vessel, then you have to use IVUS. But I think for ACS, it's a great tool, because you can see one of the things that when you're doing ACS, sometimes you undersize the size of the stent, right? So you think that you did a good job when you do intravascular imaging, you're stenting only the clot. So you have a lot of room between the clot and the vessel. So you may have an underexpanded stent, and this patient may come back in a few months with a stent restenosis. So I think it's super important to use intravascular imaging, especially in the ACS scenario.
I think there's also practical aspects that if I'm doing a CTO intervention and I'm going to have to use IVUS in that type of situation because I'm not going to be able to clear the red blood cells. I also think about whether I'm 6 French versus 7 French, whether I have a guideliner in those situations. I'm going to think more about using IVUS as well. But I really do think with acute coronary syndromes, when you're looking for a culprit lesion and you're looking specifically for plaque erosion, which can be difficult to recognize by IVUS, that OCT has a real unique role in that situation. You really are getting vascular biology with it.
I think one of the important things too, and we're predominantly an IVUS lab, and we're starting and working more into OCT, is they're very different technologies, and you have to, when you're using OCT versus IVUS, sort of adjust your eyes and your mindset to what you're looking at. And I agree with you, if you're really a frequent IVUS user, this is a little bit different image and a different way to think, and I think we need to be able to use both. And I think it does require a different sort of thought process.
Yeah, another important thing is that with IVUS, you can detect thrombus in only 33% of times, and with OCT, it's almost 100%. So sometimes we have some features of one of the other type of imaging that you can rely more on in one instead of the other one. So.
There is a downside to OCT. If you've got a 90% lesion or a subtotal, you're going to plug that hole and not get the contrast through. And so trying to make an etiologic diagnosis when you can't clear the blood is a problem. If you then do a balloon dilation, you're going to disrupt the lesion. You may mistake the etiology of the lesion. So I think it's important for fellows out there to recognize the limitation of OCT.
Those are good points. I think the overall perspective on OCT is it's so high resolution and so fantastic for the surface. So surface detection of thrombus, as you've seen here, is really spectacular. And I don't think you have to spend a lot of time subtyping necessarily, although it's wonderful to see erosion versus rupture. I think if you first can't even understand your culprit, OCT is critical. And we often see this in non-STEMI patients who have multivessel disease. And sometimes it's not clear that we're going to stent both of them. Knowing the one that's disrupted clearly will change our perspective on it. And I think we're going to hear about this next, but understanding stent failure, which happens to no one, is a really important part of seeing the surface and mechanism. So with that, let's bring up Dr. Jimmy Kerrigan to help us understand that.
Yeah. Thanks for the opportunity. And of course, this never happens to any of us in this room. Thank you. Perfect. All right, thanks for the opportunity to be here today. My name is Jimmy. I'm an interventional cardiologist from Nashville. So we've seen some great examples of where imaging is going in the future, why we're imaging in the acute setting, but then the question arises, what do we do with the patients in whom we have stent failure, stent thrombosis, or potentially more frequently in-stent restenosis in the modern era? This is still a problem. So the thought was that with the advent of drug-eluting stents that we would not see this issue. What we see is that yes, bare metal stents had a higher rate of binary restenosis, up to 15 to 20% in some series in that first year. Drug-eluting stents are better, and modern-era drug-eluting stents, we'll talk a little bit about some data on that, is potentially less than 5%. But this is a problem that does continue to accrue over time. So even if we do the best job possible, imaging-guided stents still do fail at a certain percentage every year. The answer, hopefully, as we were talking about in prior slides, in prior sessions, is to do it right the first time. So this is data from Ultimate, a trial that everybody knows. 1,500 all-comer patients coming in with acute coronary syndrome, stable ischemic heart disease, Class A lesions, Type C lesions. And what was found is that the use of intravascular imaging reduces the rate of stent failure by 40% over the course of 3 years. But it's not zero. What was also seen in this and several other trials is that if we can optimize the stent, less than 50% plaque burden at the edges, no edge dissection, and greater than 90% expansion, we can reduce that number even further to 4.2% restenosis. If we don't get the information before putting our stent in, the rates of stent failure are similar to angiographic-guided PCI overall. So again, the recommendation was to image before we place a stent and image afterwards to make sure that we're doing the right thing. But despite that, in-stent restenosis remains a problem. 10% of the PCI done in the United States, according to the NCDR, is still done for in-stent restenosis, and the management of that has evolved over the course of time, especially with the availability in the United States of drug-coated balloons. You can see here over the course of time, and this is an old slide ending in 2017. I was talking to Cal yesterday. Somebody should update this, maybe us, from this meeting to look at this. But the management of this, generally speaking, is the use of drug-eluting stents. But what we'll see in the future is that drug-coated balloons and other technologies will begin to be utilized in the United States. There are several algorithms that have been published and proposed for the management of in-stent restenosis, and just like calcium algorithms, which Sal will talk about next, all of them start with the same step: image, 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 image. This is the most recent SCI consensus document as well. And the reason for that is based on the fact that when we have a patient has a stent failure, it is important for us to understand why that stent failed, because the treatment strategies, which we won't get into during this 8 minutes, do differ for those patients as well. The data on imaging and improving outcomes in stent failure specifically is relatively limited. IOPEN was an analysis of about 1,500 patients that was done out of MedStar, looking at patients who presented with in-stent restenosis, non-randomized data, but what was found is over the course of a year, patients who had imaging-guided PCI were significantly less likely to come back with major adverse cardiovascular events. Looking at subgroups of this and the primary outcomes and the secondary outcomes, you have a statistically significant reduction in overall MACE, a reduction in mortality, a reduction in MI, target vessel, and target lesion revascularization. And unfortunately, this is the largest data set that we have for specific imaging on patients who have in-stent restenosis and stent failure. So because that's all the data that we have, the guidelines presently give imaging specifically for stent failure in both the United States and in Europe a Class 2A recommendation, not the Class 1 that we see for patients with complex coronary disease and acute coronary syndromes, and hopefully the Class 1 recommendation that we'll have for all comers in the stable ischemic heart disease update when those do come. So all of the algorithms start with imaging for us to understand why the stent has failed, because again, as we discussed, the treatment strategy matters. Here's an algorithm that has been put together and proposed. There are several others, but we'll walk through it. So when we're doing our pre-procedural imaging, we want to understand how long is the lesion. Is this a focal area of underexpanded stent that we can treat specifically with a high-pressure balloon or other technologies, or is this a long, diffuse proliferative process where we're going to have to add drug or consider intravascular brachytherapy? What's the morphology? Neointimal hyperplasia, fibrotic tissue, white without dropout behind it, is going to benefit from laser atherectomy, cutting and scoring, and then addition of another layer of drug. If you have calcific components, potentially we need to think about atheroablative technologies or lithotripsy in order to fully modify that, where the other technologies that we would use for a neoatherosclerosis may not be the most appropriate for that patient. What is the issue with the original stent? If you have this stent that is undersized or underexpanded, and we don't modify that stent and fix that, and we put in another layer of drug-eluting stent, we've made the problem potentially worse, not better. We take away 1/4 millimeter of that vessel's diameter with every stent that we place, and if all we needed to do was to go in and modify the stent was there, adding a layer of drug at the end, we may not need to add that second layer of stent. So understanding the reasons for stent failure modifies our treatment strategy as well. So once we define what happened, we need to make sure that before we add another layer of drug, whether that's cobalt chromium-based or balloon-based, we need to modify the plaque and improve that stent. So an analysis out of Italy looking at 166 ISR patients, in-stent restenosis patients, said that we want to go in and we want to pre-dilate with a non-compliant balloon at relatively high pressures, and then if you have a resistant lesion or if you have a lesion where it keeps watermelon seeding, go in with a cutting or scoring balloon. The definition of adequate result was if you had an ISR lesion that at the end of the procedure you had residual stenosis less than 30%, no major dissection that was visible angiographically, and TIMI 3 flow, that was a success. If you didn't meet all of those criteria, it was considered inadequate vessel prep. And as one might expect, for patients that had adequate vessel preparation, they did better over the course of 3 years from an overall MACE standpoint. So this is an IVUS run for a patient who came in with in-stent restenosis. Their initial MSA was 5.3. Going in with a high-pressure non-compliant balloon, 26 atmospheres, you get to 7. This is a patient's proximal LAD. We're hopefully not going to leave that there. So then went in with a specialty balloon at potentially above the rated burst pressure, and you're able to get additional luminal gain, now over 10 square millimeters. So we've been able to improve that stent that was already placed, and the reasons for stent failure in that situation was under expansion. So once we've prepared, we want to re-image and make sure before we add drug, because we usually aren't going to image after we add the drug, especially with drug-coated balloons, that we optimized. And again, the things that we're looking for, less than 30% residual stenosis, no dissection, and we've got the minimal stent area to where we want it to be, based either on our distal reference or on the location of the vessel in the left main, the proximal LAD or proximal circumflex, 7, 8, or 10. So again, we want to make sure that we've fractured the calcium, we've modified the fibrotic tissue, and we've optimally expanded those stents. Afterwards, we want to treat the lesion with drug. Ideally in the modern era, we can talk about in a different session, of course, whether that's balloon-based or cobalt chromium-based, but at the end of the day, for the majority of these cases, we're going to finish with a layer with an additional medication to try to prevent this patient from having further episodes of in-stent restenosis. So again, I put up the SKY consensus document just as a representation of the algorithms that are out there, but just keep in mind when you're seeing these patients, intravascular imaging should be first line for all of our patients, but especially those patients who have in-stent restenosis. Thanks for the opportunity.
Great talk, thank you. I think in a lot of ways, even if we can't get the average operator in the US imaging every case, operators have to image stent failure, I would say. And I think there are basically 3 questions in a way that you have to answer, and I'm curious to have you guys weigh in on this. Even if you're not a complex IVUS operator, if you can look at vessel size, stent size and expansion, and a yes or no on calcium, I think those 3 questions answered will give you most of the direction you need to treat the vessel. Any other comments or anyone want to weigh in?
I think when it comes to stent failure, really doing what's best for the patient. So, I mean, as a CT operator, I see folks come in with a couple layers of metal already in there that are really underexpanded, or there was a lot of external calcium that was never modified when the original stent went in, when the second stent went in, when the third stent went in. And I think it's almost criminal for us to continue down that path where we're not doing a service to our patients and optimizing what they currently have, and then considering the adjunct use of some of the other modalities out there like laser and that sort of thing, and then putting a DCB. But you wouldn't want to waste all that energy if you don't at least know what you're treating. And the only way to do that is with imaging.
I completely agree with your opinion, and I think that these are super important points. You understand the mechanism of the stent failure defines how you're going to treat the vessel. So if you have an underexpanded stent, most you have to expand the stent. If you have like an NIH, neo-intimal hyperplasia, I would think of laser, think of something to debulk well the lesion, and then you can go for DCB, for example. But if you have neoarteriosclerosis, I think that you have to combo with atherectomy strategies, scoring balloons, and thinking of shockwave or whatever. So I think that it's super important to, especially in stent failure, to come up with a plan. And I mean, I think intravascular imaging is going to define how you're going to treat it. Even if you have a plan, most of the time you can change your mind after assessing that and knowing what to find and how to assess the lesion.
I'll be succinct here, and I just think it's, like is mentioned previously, it's therapeutic nihilism to have stent failure or not understand the mechanism. You do need to make sure that you image in that type of situation. I'll just also add that I feel like you need to always image when you're doing a left main intervention, going a little bit off topic here. And then also, as we'll learn in the next talk, I think imaging in the situation of calcium is very important too, because it gives you a prescriptive algorithm of how to address those type of situations.
And I think especially if you're going to treat with a drug-coated balloon, if you're looking to get the level of outcome that we saw in the trials, and I sat on that steering committee, all those patients were imaged, and you can't get that level of outcome in terms of repeat target vessel and target lesion failure unless you image those patients. I don't see any way you can do that. I will say one of the things I thought was kind of funny during the steering committee was they put up images for us. There were about 8 of us trying to determine how many of us could see neointimal hyperplasia versus neoatherosclerosis in the absence of calcium. And I often hear people talk about separating the two. And for the 8 or 10 people in the room, it was particularly difficult. So don't feel alone if you have trouble separating neointimal hyperplasia from neoatherosclerosis. But what you will clearly see is calcium. Calcium is pretty obvious on intravascular imaging, and that may mean you're going to have to use a different therapy to do whatever it takes to expand your stent or optimize your lumen.
Great comments. Don't disagree with any of them. I'll just add, I think it's even more important to do it for early stent failure than late stent failure, because this is the highest risk of recurrent failure. So for those cases, I think not only should you image, but you should call your colleague in, take your gloves off, take your gown off, and scrutinize every millimeter of that stent, because this is your one opportunity to get a durable result. Late stent failure is typically different, and the stakes are somewhat different, but early, that first year, I think needs scrutiny.
We didn't see the images, but again, this is where OCT can provide particular value, as you were mentioning, Bob. It's sometimes hard. You cannot see neoathero with IVUS. Not going to be possible. Calcium, you're going to get a lot of acoustic shadowing with IVUS, so it's going to be hard to know if you have surface calcium in the neointima versus also calcium behind the stent. You're not going to be able to resolve that because you're going to have acoustic shadowing. So again, this is, for high resolution surface detection, OCT is really wonderful for this. I think that only other comment I would like to share is that when you are using imaging, you'll see other things about the stent. For example, you can see stent fractures, stent gaps, and these are ones that you would actually need to treat with restenting. But before you can do that, you absolutely have to make sure the stents are expanded. We should never put in a third layer of stent if a stent is not expanded. In general, we try to not do that anyways, and there are other therapies now with DCBs and brachy. But if we are not expanded, we're absolutely going to commit this person to a cycle of aggressive restenosis. So super important, again, to really use imaging in this way. Jimmy, any other final comments? Do you have any comments? How often, for example, for neointimal hyperplasia, when you're separating mechanisms of stent artery expansion from neointimal hyperplasia, do you choose your techniques differently? Laser, brachy, adjunctive pharmacotherapy? Can we get the microphone on? And by the way, if anyone has any questions, please do come up to the microphone from the audience.
too, but there we go, perfect. So as mentioned previously, that does modify our treatment strategy with neointimal hyperplasia, laser cutting scoring, and then a decision on brachytherapy versus DCB based on length. The number, our center's not going to let us buy more than one balloon until reimbursement got settled, and so brachytherapy is our default for longer lesions, et cetera, versus the neoathero versus the underexpanded stent. So again, looking at vessels on the angiogram, you can't tell the difference often without adjunctive technologies, and stent boost isn't going to answer that question for the majority of these patients. The only other comment is the definition of insanity is doing the same thing over and over, hoping for a different outcome. The third, fourth, and fifth layer of stent aren't going to fix that problem. It was the problem, as Rajiv said, with that first stent, and that's our one unique opportunity to modify that before we have layer on layer, where a lot of our technologies are really going to start to fail.
I do have a question since you're here. Let's just say you image the entire vessel and you see a stent that was placed in the past and it looks wonderful angiographically. However, on your IVUS, looks, for example, underexpanded, let's say. What do you do?
Yeah, so that's a fun question too, because we'll get referrals for patients for brachytherapy, for example, and it's the distal right coronary, and then when we go in with intravascular imaging, we realize that the proximal and mid stents are also underdeployed, underexpanded. It's 3.5 and a 5.0 vessel, but it hasn't re-stenosed yet. It's been an area of debate for myself too, so my treatment strategy is to go in, treat the restenotic area with atheroablative technologies, laser, debulk, et cetera, for neointimal hyperplasia, and then I don't try to piss off the endothelium any more than I have to, and I don't go back and expand that stent proximally because it hasn't shown that error. I don't know what right or wrong is, because often we'll find those issues with intravascular imaging that we didn't appreciate otherwise. Same in native vessels, that you may have an angiographically not apparent lesion. We get patients who are referred for microvascular testing. You put the RFR wire down and start with the RFR, it's 0.75, and then on imaging there's a lesion that you just did not appreciate angiographically. So it's not microvascular disease, it's macrovascular, and the use of imaging changes our treatment strategies as well. Again, a reason that we should be doing this in all of our patients.
Great comments, thank you. So let's go ahead and introduce our next speaker, imaging for calcium, when and how. Dr. Salman Allana from my neighbor at UT Southwestern in Dallas. Thanks for coming.
Good morning, everyone. Thank you for having me. In the next few minutes, we'll talk about the use of intracoronary imaging for calcified coronary artery lesion. These are my disclosures. So we have seen that coronary artery calcification have increased overall in prevalence. We have been seeing more and more patients with coronary calcifications over the past few decades. And now it's about almost 32% of the lesions that we have in the cath lab that we treat are calcified coronary lesions. And this number is pretty much consistent across multiple observational studies. And why is it important? It's important because it affects outcomes. If you look at this data from the Horizons AMI trial, moderate to severe calcification is associated with higher MACE, higher cardiac death, higher overall death, and increased stent thrombosis. And fluoroscopy really underestimates the amount of calcium. In this study, 440 patients were actually included in the study, and angiography was only able to detect calcification in 40% of those patients. And when the imaging, intravascular imaging, was done, either with IVUS or OCT, the rate of detection of calcium was almost double, about 80%. And what do we have to look for when we do intravascular imaging? Well, not only the presence of coronary artery calcification, but it's important to assess the phenotype of the coronary artery calcification. We are all familiar with the IVUS calcium score, and these features arc of 270 degree with a length of 5 millimeter, concentric calcification of 360 degrees, calcified nodule, and a vessel size of less than 3.5 millimeter are all associated with stent under expansion. And if there are 2 or more features present, it's strongly recommended that any plaque modification strategy needs to be You also have OCT guided scores, and in OCT guided scores, if you have an arc of more than 180, or maximum calcium thickness of more than 0.5, or the length of calcification of more than 5 millimeter, in those situations, it's very strongly recommended that calcium modification strategy be applied. And of course, the use of intravascular imaging, especially OCT, is useful to detect coronary calcified nodules and to differentiate eruptive nodules from non-eruptive nodules, as we know that eruptive nodules are better expanded, but stents, however, have a poor long-term prognosis as compared to the non-eruptive calcified nodules. So this has been discussed previously. This is the algorithm of, based on imaging, how do we modify the calcified coronary lesions? And this is from the SKY statement, which was discussed previously. The most important thing is whenever we see calcium, either by angiography or suspicion of calcium based on how the balloons are crossing, or now we have a lot of patients who have CTs. Based on that, we have to image to assess the presence of calcium and for assessing the phenotype. And based on that, if those criteria which are associated with stent under expansion are present, then in those situations, it's important to do calcium modification strategies like atherectomy, intravascular lithotripsy, or specialty balloons like OPN balloons or scoring and cutting balloons. In most of these lesions, many times you're not able to advance IVUS or balloons, and in those situations, I think there should be a strong role for atherectomy, as suggested by the algorithm. Once the modification strategy has been applied, it is important that we image again to see if those calcium fractures are present that are good predictive factors to expand the stents. And what to look for after lesion preparation? Well, you can see after a rotational atherectomy or orbital atherectomy, you may be able to see the there we go. So you can see the reverberations post-rotational atherectomy that suggest a reasonable, good ablation of the lesion, and that the lesion would expand after balloon angioplasty. But ultimately, what we are looking for are these calcium fractures. And this is the most important to create so that our stents expand well. So let's do some cases that suggest the importance of calcium modification strategies and intravascular imaging. This is a 74-year-old male presented with medically refractory angina. You can see that there is significant lucencies in the mid-RCA, suggestive of significant calcium and calcium nodules. Of course, this is although a balloon crossable lesion, however, could not advance IVUS, which is again not unusual in these calcified lesions. So decided to do orbital atherectomy at 80,000 rotations per minute, and then intravascular ultrasound was advanced. And you can see that they are significant. This is a distal stent, distal segment, and you can see that there was significant calcium nodule, followed by an area of reasonably large lumen, with plaque, and then as we come back into the proximal to mid-right coronary artery, you start seeing areas of concentric calcification and large calcified nodules. Well, based on that, I decided to, of course, this lesion is not prepared. You can't put a stent in. Decided to do orbital atherectomy runs at 120 rotations per minute, followed by Wolverine cutting balloon. Did intravascular imaging again, and you can see on top, this is a distal lesion that is ablated reasonably nicely. You can see the fracture at 11 o'clock. However, the proximal segment is still not ablated. You still have areas of concentric calcium and significant nodule protruding into the mid-lumen. So did more orbital atherectomy, followed by shock wave in the proximal segment, and then did balloon dilation high pressure, checked on 2 orthogonal views that the stent was expanding okay, and then decided to stent. Good stent expansion in the distal and the proximal segments. Post-dilated, post-IVUS run, the proximal segment, there's eccentric expansion. However, the area is 16 millimeters square, so I was satisfied with that. The distal stent, there's some malapposition of the stent that was corrected using a 5.5 compliant balloon, and post-IVUS made sure that there's good apposition and expansion of the stents. Final angiogram showed good angiographic result. Another case, you can see 76-year-old man with prior CABG with end-STEMI. You can see significant calcified coronary lesion involving the distal left main into the circumflex and LAD with TIMI-1 flow in the circumflex. The lima to diagonal artery is patent. However, there is a stenotic lesion proximal to the anastomosis. So again, wiring the LAD was not difficult. However, could not advance the wire into the left circumflex artery. IVUS would not advance. Again, not uncommon with these calcified lesions. decided to ablate the LAD with a orbital atherectomy at 80,000 rotations per minute. And subsequently after that, did multiple attempts to wire the circ and finally was able to reverse wire into the circumflex artery, into the obtuse marginal, a blocking balloon in the LAD, and was able to get Takeda balloon, subsequently a turnpike LP, and did orbital atherectomy from the left main into the left circumflex artery. I wasn't optimistic that I would be able to advance the IVUS, so did shock wave and high pressure balloon inflation. And this is after the atherectomy. And you can see the circumflex, if you focus on the left, there are cracks on multiple cracks in the left circumflex artery. And as we come back, I went in again, and as we are coming back, there's good ablation of the nodule, and you can see some fractures in the nodule too. So this was finished by bifurcation DK Coulard stenting strategy, part, kissing balloons, and subsequently a final angiogram. Final result showed good stent expansion and apposition throughout. So overall, intravascular imaging is standard of care in the treatment of calcified coronary lesions, in the assessment of phenotype of coronary calcification, determination of calcium modification strategies, and determination of adequate calcium modification before we decide to stent the artery. Thank you. Happy to answer any questions.
Great, thank you. That was just some outstanding cases. I was wondering if you have any guidance about thoughts about how you're going to evolve your treatment for calcified nodules in particular. This is really where our field is really struggling to have a systematic approach. They're a vexing problem. How have you been thinking about this as you're doing more and more imaging?
Yeah, that's a great question, Farouc. As we know that we don't have much data and we don't know how to treat these calcified coronary nodules, how to treat eruptive nodules versus non-eruptive nodules. But my algorithm has been pretty much if the balloons and the IVUS don't cross, I go for upfront atherectomy. And most of the times, almost 90% of the times, if there's a calcified nodule, my threshold for atherectomy actually goes down significantly. I do repeated runs to make sure that there has been ablation of those lesions. Most of the times, I didn't show that slide, but what we've also seen that after the IVL was commercially available, we're actually seeing use of double modalities in treatment of this calcium, especially calcified nodules, using IVL plus atherectomy, cutting balloons. So that has gone up significantly, and many times it's not uncommon that, especially with treatment of these calcified nodules, that we have to use at least two modalities with atherectomy, either shock wave or OPN, or with cutting scoring balloons. But again, have to keep in these. My threshold for repeated imaging is very, very low, and I keep imaging until I actually see that there's adequate ablation of those calcified lesions before I decide to stent.
Great. We have a comment.
Specific to the nodular calcium, does anyone think that it's time to bring back directional atherectomy for those?
I barely remember using it, but it's. I think the general concept of modifying it by, there's to credit Ziadali for basically coming up with this term, shave and shock, as a way to modify the surface before applying kind of deeper balloon-based algorithms. We know, the reality is the recurrence rates are very high, no matter what you do. In the 20 to 40% ISR rates at 3 to 5 years, it's really a vexing problem, and there can be tissue regrowth through the stent struts of calcified spicules, and so it's very, very hard. There's something about the geometry as well, and so kind of normalizing flow patterns and hemodynamic disturbances may also be better if there's truly an ablative component to this, not just a push with a balloon.
Yeah, I think your comments are perfect, and I think when we see nodular calcium like you showed, especially in that right coronary case, I know right away that we don't do much orbital, but I do a lot of rota. And I know right away I'm going to have to treat that, and I'm going to rota that, actually with a bigger rather than a smaller burr. So I may start with a 175, upsize my guide a little bit, start with a 175, and I agree with you. Almost certainly you're going to have a second specialty device, and We're going to see some results from Shortcut, I think, at TCT, which was randomized cutting balloon versus shot or IVL after both before and after rotational atherectomy, which I think will help us. But we're definitely using multiple modalities for that, and they are the biggest headaches and most difficult cases I think you can do, and I don't think anyone would deny that.
I think for calcification, OCT is a better tool than IVUS because you can literally draw the calcium, so you can have a better plan. If you have protruding calcium, to do some kind of atherectomy. If you have like more deep calcium, to go with shock wave, so that you can have a better stent expansion. So I think this is one of the indications that I would prefer OCT over IVUS. I don't know if you agree with that.
And they're definitely complementary therapies, IVL, rotational atherectomy, cutting balloon, all these. It's not one or the other. They're definitely complementary therapies.
I'm just going to be, I'm sorry, being the naysayer. I don't mean to be the naysayer, but just I think we need to recognize that we don't have that holy grail of here's the IVUS, therefore we must do atherectomy. And that's what we all want, right? We all know there are cases of napkin ring that will crack with an NC balloon. So we don't have that yet. And it's not like there's no downside to rotor orbital, right? There is that elevated risk. So I think long as we're aware as a community, we recognize the limitations of some of our internal algorithms. Where I think, and those cases were beautiful, by the way, where I think there is a real good use is assessing what you've done. And you showed that nicely with your intra-procedural post-ablation IVUS to really show that we've made a difference. So I think that, to me, is a perfect use for IVUS. To decide which atherectomy tool, I don't think we're there yet.
So should we move on to our next talk, How Imaging Saved the Day with Dr. Davies.
Good morning. Thank you for this opportunity. I think in our careers, we all have a case that is humbling and anxiety-provoking all at the same time. So I'm going to show you a case that imaging helped me save the day for her. My disclosures. So this was a 50-year-old female, history of hypertension, hyperlipidemia, who presented to an outside hospital with new onset rest pain that had started earlier in the evening, and then her partner convinced her to come in around 1, 2 in the morning. And her EKG was concerning for a posterior STEMI. So you'll see here the operator got femoral access and did some angiograms of her left system right away. And I think what you can quickly appreciate is that beyond the left main, her coronaries don't look bad, maybe tortuous, but not bad. But there's definitely something going on in the left main. To further enhance that, he took a couple additional pictures here that really lays out that there's likely something kind of going on from the left main into the ostium of the LAD, and now you can start to see in the spider projection that there's not much in the way of a circ or a ramus any longer. And then you can start to see now her heart rate is obviously a little bit more elevated just from this angiogram alone. But the RCA is huge, maybe a bit tortuous, but certainly not much in the way of coronary disease. So then the next images that are obtained was a wire kind of searching for some advancement into the coronary space. And this was shortly after these images were obtained. I got a phone call from the outside hospital saying that she had critical left main and needed to be transferred for urgent evaluation for surgery. At around about the same time, there was some noise in the background, and she started to fibrillate and code, so they started doing CPR on her, and ended up putting a balloon pump in and giving her some high doses of neo, some epi, the full milieu of trying to do resuscitative measures. With that being said, the surgeon got on the phone and quickly said she doesn't sound like a surgical candidate now. So this is kind of where having the ability to use your imaging catheters to help you certainly help. So multiple attempts were made to wire and reestablish flow, but were unsuccessful. She had CPR and ROSC ×2. She was subsequently intubated, and a balloon pump was placed, and then she was transferred to our cath lab. And in the time that she was airlifted from the outside hospital to mine, I just prayed really hard that she was just going to miraculously get better, which never really happens, right? So with that being said, we brought her to the lab right away, switched out the balloon pump for an Impella, and did a right heart up front just to kind of see, is the Impella enough, or do we need to cannulate right onto ECMO? And with that being said, the surgeon was in the background of the control room, waiting to see kind of what was going to transpire. With that being said, though, her right heart numbers weren't terrible. So she was compensating pretty well now that she was on Impella CP with an output of 4.8, index of 2.7. Her PAPI was sort of borderline at 1, but her CPO was 0.92. So she was tolerating. So now it's a matter of, what do we do? I elected to do a JL5 or JL4 guider. This is not my typical guider for left main interventions. I tend to do EBUs across the board, but for a situation like this where I just want to do kind of a soft injection and be suboptimally engaged because I don't want to make matters worse than what they are, I kind of took a cusp injection just to see what my flow was. And you can see the flow is maybe a little better. Keeping in mind I'm not fully engaged. With that being said, I'll let this play. So I took a soft wire and quickly wired into the false lumen that had been wired before. It looked like it went in the trajectory that we wanted to go into, what a circumflex would be. Here's the IVUS run. And you can really appreciate, if this works, yeah, a huge hematoma, and then the true lumen is kind of schmushed outside of where my wire is. And I just let this kind of play all the way back to the ostium of the left main. Again, pretty significant findings that I am in the false. Again, pretty large hematoma in the left main, complete compression of that true lumen off to the side here. So this would be like the time that if you didn't know what you were looking at, and sometimes I think in the CTO space we get very used to seeing false lumens, true lumens, hematomas, that sort of thing. So knowing not to put a stent in and not do any additional ballooning or anything into the false lumen is ideal. Sorry, if I had control of this, we could zoom through a little faster, but I'll let it play here. So still that...
So maybe you can take a little break here and have a great panel over there. So what do you guys do at this point? So the wire is false lumen. It would be great to hear your thoughts.
I will add here now, at the very ostium of the left main, we are true. But now, what would you guys do?
I'm glad they came to you, Rhian, that is for sure.
I wasn't.
You're definitely going to have, a lot of work cut out for you, but the most important recognition is you used imaging up front to understand the mechanism. In a 50-year-old without, severe risk factors, looking at that, I think everyone on the panel is concerned about SCAD as well as a primary therapy, and we were just talking about that. It would have been also reasonable at that moment to take a shot in the aorta and choose to make sure there was not an aortic dissection, because even the entrance to the left main looks a little bit small. If that was not because if the aorta is dissected, you have clear surgical indication. And even in SCAD with left main involvement, you have clear surgical indication. So, having the surgeon there was great, even though they initially said, I'm sure they were reassured once you got better hemodynamics and realized the person is 50. This is also another case for ECMO up front, rather than, having to have that risk of collapse. It may not be possible at another satellite, but that would be on my immediate mindset almost right away. I think it was great that she stabilized. Technically, this is going to be in your skill set, of course, as a CTO operator to try to maintain true lumen contact. Clearly the goal is to have a wire down true into the LAD right now. That is the most important thing, and then start to understand if you can re-enter in the circumflex. I think would be the case, assuming they're hemodynamically stable enough. Otherwise, I would just have the surgeon say, please take this person now.
Yeah. I was just hoping that the surgeons were going to say, we'll take them, but they didn't. But, pardon?
I'm curious to curious to see where you go next. Are you
Yeah.
going to leave that wire down and try a parallel wire? Or that might be where I started this little adventure.
Yeah. No, and that's kind of where my head was going. Because so I know that I'm true lumen right at the ostium of the left main proper. But beyond there, my wire goes into a false lumen. So I started true, which was evident on the IVUS run. And this is one of the biggest things I find when I'm looking through reports or talking with operators is everybody uses their own wire strategy, but in my opinion, in these sort of cases, trying to use soft wires is ideal. For me, I had the wire that had gone into the circumflex, which was a false lumen, was just a suo. And I opted to just do a Xi'an more from a different wire, see if I could do it, and a dual lumen microcatheter. So I left the wire that was false and then but true at the ostium of the left main and put a dual lumen microcatheter over that to see then if I can find the right location. And what you'll see here is I was able to wire. So now I'm in the true, and you can see still extensive hematoma all around the circumflex, coming back into the left main. And then off of now my true lumen wire, I put the dual microcatheter over that and wired into the LAD knowing that the wire now is in the true circumflex. And now I can use that to my advantage with the dual lumen microcatheter to get a second wire in a true lumen in the LAD. But again, no contrast is being given, only IVUS imaging is being used, because what I don't want to do is make the hematoma worse. But now I'm confirming that all my wires that I'm going to work over are in fact in the true lumen. And then it's a matter of what do you do in these situations. I don't think there's always a right answer for it, but in my opinion, if I can reestablish flow without putting metal, I think that would be the better option. So I ended up doing a bunch of cutting balloons. I did a 2.5 in the diag, a 3.0 in the LAD, a 3.0 in the circ, and then a 3.5 in the left main. I don't know if that's right or wrong or the best option, but I figured I can always add metal if I can't reestablish flow or she becomes hemodynamically unstable. With that being said, I was able to reestablish, by no means does it look like an A++ job or a stellar. She still has evidence of hematoma in that left main, but she at least now has flow into the circ, the ramus, and the LAD. The only part I will state to you is this apical portion of her LAD. If you remember on the initial angiograms, was quite small and atretic, which probably means that the hematoma kind of extended all the way down there. And I didn't want to push my luck because I knew I had reestablished flow in the proximal portions of her vessels. So she subsequently was able to get off the table. Her echo done later in the day was 25-30%. 2 days later, it had improved to 40-45% with some apical hypokinesis. We were able to remove the impella 3 days later. She ended up being diagnosed with FMD, which I would say is a diagnosis that should be evaluated while they're still in the hospital. She was subsequently discharged on hospital day 7, and she had an echo done about 6 months later that had normalized on her echo. She follows with a whole bunch of us now, vascular cardiology, hemonc, nephro. She fortunately did quit smoking, and she's exercising regularly. I will just add that recently in JACC, they published this great paper that kind of goes through the algorithm that if they're stable, try to medically manage. If they're not stable, really consider upfront surgery or PCI techniques. But ultimately, support can be very advantageous for these folks to kind of ride out the storm. But if we can conservatively manage, better off with that. Ultimately, she was diagnosis of SCAD. It's certainly an individualized approach. Using imaging, I think, to me, certainly saved the day for her. And we ended up avoiding putting any metal or having her undergo bypass surgery with the use of cutting balloons. But consider MCS. Thank you.
Quick question, any role of CTA for surveillance in hospital or remotely?
Yeah, so before she actually left the hospital, I should have added that we did get a coronary CTA probably on hospital day 6, and things actually looked pretty good. We'll have her continue to follow. I don't know if there's a right thing on timing, but we asked that she get it done. Her 6-month echo was about a month ago, so I think she's due to get another CTA here.
Thanks, Ryan. Great save, everyone's worst nightmare. But I think one thing you can also consider, once you got true lumen in the circ, you can use your false lumen wire to start back, and that will help drain the hematoma a little bit in addition to cutting balloon. I think it works. Sometimes I think Japanese are pioneering a lot of the work with like tip detection, ADR. So they do this frequently, so that once they go back to the true lumen, they start with the false lumen wire, and that creates a big fenestration and help drain the hematoma.
Rhian, brilliant save. First of all, I think you deserve a real congratulations. The patient was very lucky to have seen you. To me, the sobering thing about this, it reminds me, when I watched your first wire go down, we would all have said that's true lumen, right? I mean, we say that, oh, it's look and feel and side branches, but that was false lumen. So I think that's the lesson that we should all take. Don't rely on the look and feel in all cases. The IVUS saved the day here.
Yeah, it's an amazing case, and I think that patient dies in a lot of other people's hands, so congratulations. But because of that, I'm very curious, until you knew your left main guide was in the true lumen at the ostium of the left main, and then you had your Suzuki or whatever dual lumen catheter there. Could you describe a little bit better to us how you actually tried to engage and wire that true lumen for us?
So I had the suo in the circumflex in the false lumen, and the dual lumen microcatheter was sitting right at the ostium, and I just put a J-bend on a Xi'an wire, like just a soft J-bend, and that was able, so I didn't make any fancy sort of bend, but I could feel that it, or angiographically too, it was lower than where that suo was, so I assumed that I went into a different track. I still didn't know, because the prior operator had put in some jacketed wires trying to find the lumen. I didn't know if I was going in and out of those, so it wasn't until I IVUSed it that I really know. But I just knew that I was true lumen where the dual lumen microcatheter was sitting, and where that second, so I put it so that the second port was kind of right there, so I knew that once my wire comes out, that's the highest chance that I'll get into the true lumen.
And that you felt was statistically better than trying to wire through the left main guide itself that was in the true lumen. You know, in terms of just
because
free
I wasn't perfectly engaged with the JL. I was actually floating in the aorta when I took
Okay.
that picture, so I kind of remotely free wired into the circ originally.
Okay, thank you.
Yeah.
If you're going to do that, which is,
Yeah.
this came out great, the stabilizing aspect of the dual lumen is very helpful. But otherwise, if you were trying to think a second system, using a microcatheter, incredibly helpful. Also, an angulated microcatheter, like a supercross, sometimes can help you redirect away from the false lumen side. So those are some other techniques. And then I did want to ask Rhian and Stefan a question. Have you ever just kept your false wire in and directly aspirated with the microcatheter?
Yeah, I
as
think
you're ballooning in the true lumen? Will you aspirate in the false lumen and perhaps decrease the amount of hematoma upstream?
I think that that would have been a good step to have done. I didn't do it in this particular situation, but I think anytime you can kind of decompress or remove some of that hematoma, it probably sets you up for an easier wiring ability. Yeah, I think that's a great idea.
That was my comment. I have almost like a cut and paste, same situation case that I did about 2 years ago, and to wire the true lumen, what really made a big difference is to park the microcatheter and to straw it there, and it reopened very nicely the true lumen, and then afterward I was able to wire the true lumen very easily. So it's certainly something to explore, but we're always concerned about instrumenting more into the false lumen and then losing further flow and everything. But I think if you're out to do it, I would recommend like as low profile possible, like fine cross or, Mamba flex or something that will have like less real estate and maybe more, and then you can work through it. But that was a great save, good job.
What size guide was that? So you couldn't keep the IVUS in the...
I have a 5 French, but no, I didn't.
Just one final comment. When we looked at on OCT the intermedial thickness of SCAD, I mean, it's much, much thinner than you realize. Something like 20 or 30 microns, just a few cells thick. So you don't I mean, I think in this case, it was just such a spectacular case. You used a cutting balloon, but for other cases, I would say you don't need cutting balloons. A standard one-to-one semi-compliant balloon will fenestrate that lumen. It's not like CTO atheroscalcific disease, but in this case, because it was a left main, because you had all the imaging, I think cutting was fantastic. But just as a generalizable thing, I don't think people need to be sending cutting balloons down to the distal circ when a regular balloon will do. But again, a brilliant save. I think another round of applause for this.
Okay, and I think for our last talk of the session, we get Dr. Allana back for imaging and CTO. Thank you.
Thank you. Thank you. Good morning again. The next few minutes, I'll talk about the intracoronary imaging for chronic total occlusion, PCI. My disclosure. So normally, of course, we have two intravascular imaging tools commercially available at this time. And OCT, mainly for CTO PCI, is utilized for stent optimization. And although despite lower resolution with IVUS, there are multiple other features of IVUS that are very, very important to know and are preferable to be used in CTO PCI, especially the penetration depth, the manual ability to do manual pullback, real-time visualization, and no injection of contrast to avoid expanding the subintimal space. And however, the IVUS utilization CTO PCI is subpar all over the world. In Korean registry is about 39%. Even in Japanese registry for CTO PCI is about 56%. In the UK, 38 to 44%. And Progress CTO is about 44%. However, if you look at the trend of utilization of IVUS in CTO PCI from the Progress CTO registry, the use has increased to about 60% in 2022. So does it matter? Does IVUS, we know that IVUS helps in regular PCI, complex PCI lesions. Is utilization of IVUS improve outcomes in CTO PCI? This is a meta-analysis of 2 randomized controlled trials and 2 observational studies that actually shows a trend towards better outcomes, which were not statistically significant. However, there was a decreased risk of stent thrombosis in the IVUS arm. We know the results of the Renovate complex PCI trial, and important to note that 20% of all lesions in the Renovate complex PCI were CTOs. And if you look at the subgroup analysis, the CTOs, the IVUS-guided PCI had significantly better outcomes as compared to angiography-guided PCI alone. Even in retrograde cases, it's used for about 60% retrograde cases in Progress CTO registry to assess for proximal cap ambiguity, to facilitate wiring, facilitating reverse cart, and for stent optimization. So perhaps the most important utilization of IVUS in CTO PCI is for the proximal cap ambiguity, as also suggested by the global CTO crossing algorithm. As you can see in this patient with the RCA CTO, you have an ambiguous proximal cap with the side branch around the cap. As you can see, the RCA is occluded, reconstitutes distally, and then there's another chronic occlusion of the right posterior lateral artery. So in this case, IVUS was advanced into the right ventricular marginal artery, and the pullback was performed. And you can see the cap coming in over here off the right coronary artery, the proximal cap coming in around 10 o'clock. Importantly, another thing to assess is that there's not much calcification of the cap, and therefore, in this case, I used a polymer jacketed Pilot 200 wire and advanced Pilot 200. And you can see that the Pilot 200 goes into the proximal cap. However, subsequently, this was further wiring attempts went subintimal into the extra plaque space. So knuckled a Mongo and then used Stingray to enter into the distal right coronary artery. Then went into into distal right coronary artery with the wire extending into the posterior descending. And subsequently attempted to wire the posterior lateral artery, which was unsuccessful, and used a recross to subsequently do ADR into the right posterior lateral artery. The next was, of course, IVUS. This is the IVUS run. You can see the IVUS starts here. It's a Boston IVUS. So, you have a true lumen. So I re-entered the PL pretty distally, which was expected because it was all diseased. But as we are coming back, you can start to see the true lumen of the right posterior lateral artery proximally. And as we come back, you can start to appreciate the wire coming from the right posterior descending artery, confirming that my first re-entry was in the distal right coronary artery. As you can see, the wires coming. So my first re-entry was actually in the distal right coronary artery with the stingray. So in this case, I decided to stent from the proximal to the distal right coronary artery and did DCB of the right posterior lateral artery with the plan to bail out stenting. Had good flow and therefore did not decide and decided against stenting the right posterior lateral artery. If we use IVUS for proximal cap ambiguity, it's best to use the short tip solid state IVUS, which has a tip to transducer distance of about 2.5 millimeter as compared to standard tip, which is 10 millimeter, and the Boston IVUS, although it gives excellent resolution, the tip to transducer distance is about 20 millimeters. So you need some length if you really want to use that IVUS. IVUS is used for facilitation of reverse cart, assessing the position of antegrade and retrograde wires, and that can actually have different solutions. And so this was a case that highlights it. Again, you can see 66-year-old male, ambiguous proximal cap with a side branch at the proximal cap. IVUS-guided re-entry, IVUS-guided puncture was unsuccessful, and so decided to go a retrograde, and it was an extensively difficult reverse cart. Did contemporary reverse cart initially, however, this failed using draft, guideliner, and so did IVUS. And you can see that my retrograde wire is actually in the subintimal space and my antegrade wire is actually a true lumen. So this is an unfavorable situation, however, can be solved by creating a dissection in the antegrade, on the antegrade wire. Also importantly, the lumen of the right coronary artery is about 4 to 4.5 millimeter, and I have been using 3 millimeter and 3.5 millimeter balloon. So I was now more comfortable using a 4 millimeter balloon, and then successfully completed the reverse cart, 3 overlapping stents on the proximal to distal right coronary artery with good angiographic result. IVUS is extensively used in the assessment of retrograde wire reentry. This is a case where the LAD is jailed by the stent from the left main into the diagonal artery. This was a case performed retrograde, and using CART, the retrograde Gaia X3 was advanced into the aorta successfully. However, the important thing to note is where exactly is the wire entering into the left main. Is it entering distal or is it entering proximal to the left main? Because if it's entering proximal to the bifurcation, then stenting would create closure of the left circumflex artery. And as you can see, this is an IVUS into the diagonal artery, and we came back, and clearly the re-entry is proximal is distal to the left main, distal to the bifurcation. So access to the LAD was obtained, and good final result. IVUS used for antegrade dissection re-entry. This was supposed to be a straightforward end-STEMI case. However, the guide dissected the right coronary artery. And so patients started having SC elevations. Of course, decided to, for antegrade attempts even with the soft wire, I agree with Rhian, use soft wires in these kind of situations, SU03 or SION. However, these were unsuccessful. So went into, with the Stingray. However, multiple attempts were unsuccessful. So put an IVUS catheter down, and you can see the false lumen is completely compressed, large intramural hematoma. The true lumen is completely compressed. There's large false lumen with an intramural hematoma. And the other important thing this IVUS showed me was that there's not much calcium in the reentry zone. So we put a Corsair Pro XS into the subintimal space and connected it to the penumbra for continuous suction. And then used ADR, Stingray balloon, successfully while the compression was being performed, re-entered into the posterior lateral artery and got a good final result. IVUS has been extensively being used, especially among the Japanese operator for tip detection ADR, where they use simultaneous use of fluoroscopy and IVUS to detect and direct the tip from the false lumen into the true lumen. certainly that we as American operators are learning. However, Jay actually and his group published a case with TD-ADR using HD IVUS pretty recently. So overall, intravascular imaging is utilized in multiple ways. It improves outcomes and should be strongly recommended in CT or PCI. And of course, it's a class 1 for complex lesions, and there's no more complex lesion than CTOs. Thank you.
Great presentation, a range of cases. Congratulations on doing a lot of complexity. And I think it really just shows you that when you have a high-definition IVUS catheter, being able to resolve true versus false lumen is incredibly valuable, as we also saw with Dr. Davies' presentation. I was wondering, anybody have any further comments about aspects of CTO PCI that they have found imaging to be useful in?
I think one of the big areas, I think that case highlighted it very nicely, is when you're going retrograde, you wire protected the vessel kind of proximal to where you're going to re-enter, and confirming before you start advancing gear through there that you're truly in the same spot so that you don't shut down the other vessels. So I think in those instances, without imaging, it'd be next to impossible to do.
We're a little bit run over, so I think at this point I'd like to thank all the speakers, the panelists, my co-moderator, and thank you all for your attention.